I'll be talking about posterior stenosis after radiation and after anti-BPH procedures. Couple of slides, few slides on background. We'll talk about surgical options and the state of evidence. We'll discuss excision primary stenosis versus buccal mucosal graft approaches. We'll ask a question: what is the ideal operation? It's a surprise. And we'll concentrate on outcomes, specifically on patency and continence. So we'll be talking about bulbomembranous stricture, anastomotic contracture, and bladder neck stenosis. Only the middle one, anastomotic contracture, is where there is no prostate, and the other ones where the prostate exists. After brachytherapy, the posterior stenosis may occur up to 32%, less so after external beam radiation therapy, up to 4 to 5%. Usually comes as a delayed presentation, more than 2 years after the treatment. When patient arrives, we do detailed history, limited physical exam, some labs. PSA is important to make sure that there's no recurrence. Uroflow, PVR, and assess continence status. Cystoscopy and imaging. In cystoscopy, you would try to find this atrophic calcifications, cavities, and you may find defunctionalized bladder. In that case, you'll do urodynamic study too. We do retrograde ureterograms and VCUG preferably, and supplement or augment our studies maybe with ultrasound, CT, or MRI if you're looking for additional pathology. This is how it may look. Typical vesica urethral anastomotic stricture, no prostate. Post-brachytherapy necrotic cavity here. That's not the bladder. That's a cavity full of stone and crud and necrotic tissue. And then a typical post-external beam radiation stricture or stenosis, and you could see the fiduciary markers there. You heard about all these options, endoscopic, diversions. We'll concentrate on reconstruction. Decision-making is, number one is a patient preference. And then oncologic status, overall health, quality of the local tissue, status of the bladder, continence status, is there still prostate, what is the length and location of stenosis, and very important for me is it obliterated versus non-obliterated. You saw a very similar algorithm proposed by Dr. Flynn in 2018. You could see that for post-prostatectomy anastomotic stenosis, you could have abdominal perineal approach, could be robotic or open. For bladder neck with the prostate in place, Dr. Flynn described all this YV-plasty, T-plasty, and I underline my favorite, subtergonal inlay with buccal graft. And originally, for short strictures in bulbomembranous or sphincteric area, for short strictures, you would offer EPA, excision primary anastomosis, and for longer, dorsal-only urethroplasty. And then I changed this algorithm slightly, so if it's obliterated, I reluctantly would offer excision primary anastomosis, not my favorite. And in any stenosis that I could place a wire across, to me it means that I can get away with dorsal-only urethroplasty. This is the table that we use for that publication. You could see that from 2006 to 2017, there were very few studies, 10 studies describing outcomes after radiation stricture repairs. Most of them were either mixed studies or pure excision primary anastomosis studies. Only 2 studies were augmentation studies with buccal graft, either ventral or dorsal. The summary is here. Success rate was similar, but the number of total patients was 214 in one group and 59 in another group, with a very similar success of patency. The largest study about excision primary anastomosis came recently. That's from a Turns group. 10 institutions, 137 patients, variety of radiation approaches. Unfortunately, hospital stay was not reported for this very simple and easy procedure. This is just few stitches. You cut the stenosis, you reanastomose the lumen, except it's not such a simple procedure. If you look what they had to do, corporal splitting, corporal rerouting, partial total pubectomy, salvage prostatectomy, gracilis flap in many patients. And that would be nice to know how long patient stayed in the hospital here. Success rate after 32 months was pretty good, 13% recurrence rate. What was remarkable is stress incontinence was on average 32%. Now, what is excision primary anastomosis? It was described for benign, non-radiated, maybe traumatic cases where you excise the affected tissue and you reconnect healthy, vascular, unaffected, patent lumen. Good tissue to good tissue. Except after radiation, there is no good tissue proximally, and there is no more good tissue distally because you just transected the bulbar arteries. So I don't know what your anastomosis success rate is pretty good, but how? I'm not sure how. And then what did you just excise? Majority of the strictures after radiation are in a sphincteric urethra. So you just excise sphincteric urethra and put the edges together. So same table from before. If you look at the incontinence outcomes, after excision primary anastomosis, up to 40% de novo incontinence, between 0 to 10% after buccal grafts. So if you had to invent a surgery from scratch for radiated stricture, you would probably preserve urethral continuity, you would avoid excision of sphincter, avoid disruption of antegrade blood supply, or dissection, which is, to me, it's the worst part, dissection near radiated rectum. You don't come up with the EPA if you were to invent. I propose dorsal-only urethroplasty with buccal graft using Kulkarni approach, but proximally. One-sided dissection, excision of the dorsal wedge until you find a good lumen, sharply. Don't use cautery here. And then just parachute that graft dorsally, quilt it, and close it. We initially published it in 2016 on very few patients, and then shown the video and tried to persuade people. So fortunately, we have another 9 friends from 10 institutions, accumulated 79 patients. We didn't get any rectal injury. Majority of patients went home on the same day or after overnight stay. And the follow-up, very similar to the EPA study. Stricture recurrence was very similar, under 20%. What was the key is the de novo incontinence happened only in 8% of patients. Then we concentrated our effort to weed out specifically the worst of the worst. This was the study for prostatectomy and radiation in whatever order. And 9 institutions contributed 45 patients, again, no rectal injury. Most patients went home after a short stay. After follow-up of 22 months, there were 5 stricture recurrences, 13%, and there was no de novo incontinence. And by the way, remember this dogma, you cannot put buccal mucosa on a radiated field. You can, and it will be successful, it will survive, it will imbibe and enosculate, or whatever you call it. After 12 months follow-up, you could see endoscopically that there is a buccal graft that is surviving and imbibing. Very briefly, 2 or 3 slides on after anti-BPH treatment, stenosis. The very first publication was in 1989 by Professor Mandi. The quote was, "Surgery should be avoided if at all possible, and reliance placed on urethral dilation." So I think generations of reconstructive urologists followed this and just dilated or self-dilated these patients until arrogantly us with Blakely and our friend Javier Angulo from Madrid just published separate papers on dorsal buccal mucosal graft, 14 and 16 patients, and we described 0 de novo incontinence independently. Later, 2 studies came out about a ventral buccal graft in the same population, totaling to 99 patients, 4%, 7% de novo incontinence. And our friends came together with 107 patients dorsally. There was 1 patient out of 107, 0.9% de novo incontinence. So huge improvement over the original publication by Professor Mandi. And interestingly, EPA is back in favor. Excision primary stenosis, Dr. Gomez published on intrasphincteric or sphincter-sparing EPA with a much lower de novo incontinence of 15%. And another group from South America published just a regular standard EPA, 77 patients, good success rate, 8% de novo incontinence. So stenosis after anti-BPH treatment, we don't know what is the best treatment. I don't know if it's time to make guidelines. And is it time to follow guidelines at this point? Is it time to challenge the dogma? You decide. Send me a text. In summary, dorsal-only urethroplasty with buccal graft is a feasible option, both after post-TURP and post-radiation. The success rates are similar to other described technique, be it ventral or EPA, and I think it's encouraging results and improved rate of post-op incontinence. Thank you.